we are moving on with the live case session. Vlado, please join to us. And I would like to ask Dr. Nenov to present the case, which we'll be looking after a minute.
Good morning, everyone. Now I'm going to present the first live case for today. It's 58 years old male patient with high-grade effort angina. The patient is with two-vessel disease. December 2025, he was with non-STEMI, and we performed PCI of the circumflex artery. The patient is with hypertension, dyslipidemia, diabetes, and also he is a current smoker. From ECG, we have sinus rhythm with some ST depressions and negative T waves in inferolateral leads. From echo, preserved left ventricular function with mild apical hypokinesia. This is the index film. You can appreciate the circumflex before and after stenting, and also CTO of LAD in mid-segment. You can see that two bifurcations are involved. This is the CTO and some changes in the right. We performed dobutamine stress echo, and we have inducible ischemia in 7 segments in LAD region. That's the case.
Okay. Hello, Valery. Did we have a connection? Hello, George.
You start, Valery. Good morning again.
Good morning.
What a pleasure to be here. Many times, Valery. Thank you very much, Dr. Dobrin, Dr. Geller, for having me. We have a very interesting case for you. I think that Dr. Geller or Dr. Zeleva will introduce the case, or who is going to present it, Valery? It's already presented. Okay. So this is the perfect case for what we're calling about bifurcation and CTO together. Let me show you a little bit what we have. We haven't done anything yet. Just want to introduce to you the scenario. So we have an 7 French femoral and a 6 French radial, AL1 in the right coronary artery, and an EBU 3.5 in the left system. And this is the first combined injection, as you can appreciate here. And to my interpretation of this anatomy, Dr. Geller has fixed the bifurcation of the circumflex, as you have seen. And if we go frame by frame to this anatomy here, you will see that there is an ambiguous proximal cup. I will just stop it here. So you see the proximal cup. Here is an overlap with the circumflex. But you see here there is a septal, there is a diagonal, and we're guessing with Dr. Geller where might be the proximal cup. And if you see in the distal vessel also here, there is also a bifurcation at the distal part. And this is also quite blunt, although the details of these are going to be revealed upon the progress of the case. But what we see here, there is a blunt bifurcation, there is a septal that takes over from there. So there are some collaterals from left to left. You see the distal LAD coming, it's a long vessel. So the next thing is we did this injection in the right coronary artery, and there is a septal collateral that goes up. What is interesting in this septal collateral is that there is some competitive flow within the septal. And that means that the collateral, the septal that we were seeing just before, if I just go back to this one, you see that focus just on the distal cup when the contrast is fading. There is a septal collateral in the LAD, and then there is the diagonal, and I believe that this is the same septal collateral, so the collateral that comes from the right is the same one. I might be mistaken. Anyway, this is the right coronary artery. And what we did the only thing that we did afterwards is to make a tip injection. We took a fine cross microcatheter. And I think this confirms what I was telling you, because if you see the details of focus, just forget about the right coronary artery. There is a continuous collateral, you can see it there, that goes a little bit further up. You can follow it there. And you see that this septal branch has competitive flow as the previous one, and it is entering exactly at the point proximal from the bifurcation. That is very important because if you go again to the previous one, we're just discussing a little bit the anatomy now. I'm always, when I'm doing cases with Dr. Gelef, we're discussing the anatomy with options. We don't discuss the strategy at the moment. But if you see the distal cap again, I just focus here. What is important is that this septal collateral comes a little bit more proximal from the, you see it here. It comes focus on the distal cap, it comes more proximal from the distal cap. What does that mean? That if we get access from this septal, we have length enough to work proximally, theoretically speaking, the strategy is not yet discussed, to wire the LAD in the retrograde direction, and still allowing us, after whatever we do, to get access both in the diagonal and the distal LAD, because actually here we have these both bifurcations, and our plan is to do an elegant procedure that it will allow us a true-to-true, regardless of it is undergrade or retrograde, that will preserve this, both of these bifurcations. And you see that the second diagonal branch, as the first diagonal branch, it is a sizable vessel, so it should be for both vessels the same thing. So that's the detection of the anatomy to my side. What we discussed with Dr. Gelef is that we're going to wire the diagonal and the septal, and we're going to do an IVUS. We will do first the undergrade work. We will see whether we can determine where is this proximal cuff, and should that be necessary, although to be honest with you, I'm very tempted to put a wire retrograde, but I will not do. Let's wire the diagonal first, and we do some IVUS. We see together whether we can recognize the proximal cuff, and then we can determine how we can. Can I have another run through?
Run through.
Or if we have anything here that I can. So, any comments?
George, just
about
to
that?
summarize the strategy.
Excuse me?
To summarize the strategy.
Yes, please.
The steps. You start from retrograde.
No, we
No?
will start from undergrade. All of this filming, even filming the collateral in more detail, was into the direction to clarify the anatomy. And what we know now is that essentially, if we want to move to the retrograde approach, we have one shot only. It might be some collaterals that are coming from the distal circumflex, but the epicardial collateral is not very well determined. So for that reason, we will just go to the antegrade. Let me see exactly this projection. That's a good projection. This projection is areocranial.
Can we see the projection, please?
This is straight areovalary here.
To be put on the screen.
Let's have that as a reference.
Може ли на малкия екран да сложите проекцията или обратното? Да
This is
останат
area-
сепараторите само горе в ляво. Да, окей.
Okay. Where do we see
This
the
is going to be
Ah.
cranial 36, RO9.
RAO9 cranial 36?
Ако да имам да тъмнина,
Абе, казахте, че си надебелявам, ам не ме
айде да
чуваш.
влезем
Cranial
тогава.
36, RAO9. Maybe if we work in this projection, it might be even better. So we might be able a little bit more RAO, it might show us a little bit more. Should we prepare the IVUS
Yes,
for Gillen?
it's,
I will wear the diagonal, I think, first. What do you think, Valery?
Okay.
So diagonal wiring, IVUS for the identification of the stump place.
Yeah, I think this is a diagonal, but I would go, I don't like this projection. The other one was more clear to me, so the other one was RAO 9. So let's go to 9. RAO cranial 30. Okay, this is the same projection now. A little bit of contrast, Dr. Gelov, just to see. No, I don't see very well the bifurcation now. Or this is the circumflex, that's why.
No, this was the. I think
Let me go a bicodal projection so we can wire at least the proper
So in
vessel.
Japan, usually they start in that
Yeah,
way
that's
just to identify
that's why the wire.
the stump and are there some calcium there? If it is highly calcified, just to try
It's
to
not extremely
puncture.
calcified, but certainly is calcified RAO. I think this is
Some
better.
comments from the
Yeah.
panelists?
This is a diagonal, but
No, the use of IVUS to identify the takeoff of the occlusion, so it's logical. So I will try
the
integrally.
circumflex is a big vessel. It doesn't help me much to. Let me just try to determine where. Let's make another film. Yeah, that's better. That's better. We see it good now. Okay, so we are in the right place. Here you might be able to recognize the cup a little bit better. Do you understand what I'm saying? You see that there is a little bit of a small stump in this projection.
Yeah, we see it.
Yeah.
Very small.
Okay,
But
that's good. Okay. Let's take the wire is in a smaller branch there, Dr. Gelov. I don't know.
No, it's okay.
It's okay, I think.
I
Let's
think
just-
this is
It's just okay.
after a few
Yeah.
centimeters. It's
Occluded also.
not occluded, but it branches in a small.
Okay,
branch.
let's try to see whether we can identify this proximal cup. This is a good projection because I think I see I think a little bit more of the proximal cup. Yeah, I have it already. Yeah.
Okay. You
Hey, I have the wire.
Push me.
I think that would be long enough. Let me just retrieve the wire a little bit. It goes some extra systoles. Yeah, I think we are okay there to do the pullback. Let's see how, we have to see also the IVUS. Can you see the IVUS yourselves?
Yes, we see it maybe
We're going to do the automatic
It could
pullback
be-
or manual, Valerie?
placed on the larger screen.
We do an
What you
automatic
prefer.
pullback.
Okay.
Let's do an automatic once. And then we will, if we see the proximal cap.
Starting.
Yes, please. Can you see the IVUS?
Yes.
We're in the diagonal now. We are running the pullback.
Дайте пак айвуса на големия екран, моля.
Here is, I think at 6 o'clock, this is the proximal LAD. It's a quite diffuse diseased vessel. Now we're in the main vessel. We're going to go manually back to determine. I think we can stop here. Let's stop, Dr. Geleva, and let's go a little bit back to review the film, the pullback of the diagonal, whether we can see if we can recognize the proximal cap. So let's see exactly, let's go at the point manually, a little bit further, more proximal, oh, here. Here, if you go a little bit more proximal, you will see the big septal. Here is the septal. I think at 9 o'clock, 8 to 9 o'clock is the big septal. The septal is a very big vessel. So we have to go now a little bit more distal,
No.
a little bit frame by frame, even,
Distal.
to see whether we can, just by your hand, a little bit more distal now, not proximal, distal, and see what we can see over there. A little
In
bit
general,
more distal.
the septal and the LED are at 90 degrees. So
Here, this is, in my view, if you see at 9 o'clock, if you see at 9 o'clock, you can see the ostium of the LAD. Do you agree with me? That this is the vessel and it fits a little bit in the direction of the vessel here, there. And then if you go more proximal, then you lose the vessel and you go to, this is a septal, more distal now. So I believe that what we see in the angio is here. This should be exactly, because I see a vessel structure here at 9 o'clock, this should be the ostium of the LAD. So it fits exactly where we said that it's after the takeoff of the diagonal of the septal branch, and then it fits exactly on the point that we see on the angiogram, and I will play that to you again. If you can focus again on the angio, you can see that there is a small spot there. So I think, Valeria, we can try this spot and see whether we can go integrate over there, and we can make progress with a wire. Should we take a dual lumen microcatheter or a single microcatheter? We can take a dual lumen. We'll take a dual lumen microcatheter and we'll try to puncture.
Fine duo?
Fine duo can be, Sasuke can be anything. We have 7 French, so both of them, they can do the... if we fail to do that, then we'll take another microcatheter. Any comments, from your side, any suggestions?
With 7 French it is impossible, but in general for IVUS guided puncturing, what do you think about that? IVUS guided puncturing with the 3D wiring, but with the microcatheter, but with the 7 French we cannot accommodate all this.
Yeah, we also addressed that one. I've seen this procedure many times, and I definitely respect the people that they have the capacity to do it, but I don't believe in it, to be honest with you, for one very simple reason. I know where it is, and what I call the bullseye puncture of the proximal cap does not necessarily guarantees that the progress of your wire is going to be, let's say, intimal within the occlusive segment. So I really do not, I don't believe in that one. And I prefer, after I recognize the proximal cap, to go into the direction of taking the IVUS out and work more in peace over there. But it's a very valid comment for people that they like this. Can I have now a Gaia second? Gaia second.
Gaia
yes.
second.
This regular Gaia
maybe,
or Gaia next?
I consider the Gaia second not next, but a more suitable wire in this case. You should know that the original Gaia family has a little bit better capacity to deflect. What do I mean by that? We suspect that this lesion might have a kind of a tortuosity. The Gaia next family, it's a little bit stiffer, and no need. And it tends to go more straight. I prefer a wire that, and because we are exploring the lesion here, we're working now with an intermediate stiffness wire, as you can appreciate. What does that mean? You see a little bit, we have the bump there. That's what we want. We will explore whether a wire of this stiffness can go. If it can penetrate, it will be very good, and it will give us a kind of a feeling, let's say, of about what is the... It doesn't go into the desired direction, is that correct?
Yes.
So I don't prefer the next in this case. I will go now a little bit more into
You
the
choose
cranial
to
projection.
use Sasuke, as I see.
Contrast, Valerie. We have a fine duo here.
Sasuke.
This
This is-
Sasuke?
this
Okay,
is
this
Sasuke,
Sasuke,
yes.
that's great, okay. I think this is more better direction. So we will see if the lesion is too strong for this wire to follow, then we will go for a Gaia next 3, because we will need penetrative capacity. I will just explore with this wire whether this lesion can be punctured or not.
George, what do you think about the proximal 1 to 3 millimeters subintimal dissection and going into the vessel and then guided by this wire to repuncture? Maybe.
I didn't understand the.
I mean, if you to take
Take
Confianza
Gaia,
Pro
let's take
just
Gaia
to
next.
puncture
Three.
a little
Or
bit
Gaia 3, whatever, it doesn't matter. Yes?
Gayatri.
proximally from the bifurcation, just to go subintimally, but to find the direction of the vessel and then with this double lumen catheter just to orient your proper wire.
What is the
This is the like seesaw
Yes.
wiring. But-
what is the philosophy in these kind of cases? I think this is the right place. The philosophy of these kind of cases is to always in the CTO, that's always my philosophy, is true to true is always the best thing that you can do. So, and especially now that we have the bifurcations and we sincerely want to respect the anatomy the more we can, always my attempt is to go, okay, this wire is soft. Let's take a Gaia 3. My attempt is always to go true to true. And we will see, but this one you cannot guarantee. I will not intentionally from the beginning try to go subintimal to bypass the proximal cap. But you might do it without really wanting it or not. We will see how the wires are progressing and we will see whether we can make the progress that we really want over there. But I wouldn't go as an initial strategy intentionally subintimal to get into that. We might do that a little bit in a later stage because even if we go retrograde, there is always a possibility that you need antegrade. Here, that's better now. There is an antegrade. Where is that going? No, this is going. I'm not very happy with.
Подгответе.
There is another branch there. The CTO is there, goes down. It's definitely not an easy.
Hello, George. It's Yuri Avramovich here from the panel. I'm sorry not
Valeria
being
would
there
make it
from
to
the
understand
beginning,
where
but
we are going.
are you using maybe sometimes also angulated microcatheters for cap puncturing for having better direct support, and why not, if you are?
In these cases, it's not necessary because I'll take a little bit back. Okay, we can wait a little bit. We'll give the patient a little bit. These microcatheters sometimes is because when they are very angulated, usually the angulation wire doesn't have enough. How do you call it? Stiffness to maintain the shape of the catheter.
The shape of the angle,
When
yes.
you use stiff wire. So if you take a stiff wire more than 6 grams,
Hekajet.
it will straighten the tip. So I don't find them personally useful on really puncturing a proximal cap because they don't provide enough backup support. Can I go on or wait? But I use them whenever you really need to have a kind of an. You see, this is the cup that we need. You see, but there is what we see. There is another small branch over there. So I don't use them as a catheter that to puncture. That's better. I think it's a little bit different. I'm progressing now in a more stiff tissue, but still, it's not going into the right direction. One thing that is a different, Dr. Gelov. It's a little bit different.
Yes, this is much better.
This is different from previously.
Направете.
Let me just see.
Айде грижете се за това нещо.
So in this case, I wouldn't consider. I use them mainly to have access to septals that are not easy to film.
No.
We're still very far away from the desired point. So we need to puncture far more into the direction of the LAD.
Maybe what we discuss this septum branch.
Yeah, Dr. Gelef, yes, but we discovered that. You think, Valery, that it might be.
From there, you see.
You see, we were discussing, you see, there is another branch that it is a little bit more proximal. So definitely the puncture site over there is not
You can
optimal.
see this.
Yeah.
What do you think about
Let
the
me see if I
proximal
can-
balloon inflation?
It wouldn't be necessary in this case. Can I have again? I don't know if you can see in this one. There is another branch. Do you see it? Just close to the septal. That it goes into the direction, but I don't know, Valery. It might be a branch there.
Okay, that's just.
Yeah, I don't know. We will just try to see what I think that I need here. I need a bigger. I need a bigger curve. Let me see if by any means we can puncture in this direction. Again, this is the other one. We have to find a way
This is still
to puncture more down.
Gaia 2 or Gaia Next 3?
This is Gaia 3 now.
3.
But George, what do you think that taking out the dual lumen and putting the IVUS probe on the diagonal just to have like better visualization where we're going, so you will definitely have more.
Yes.
Oh, that's perfect.
Let's make a
Should
short
be
film, Valery.
accurate.
I don't know.
Maybe another
It's
projection?
too good to be true, but so the other one was for sure an branch, Valery. For sure a branch. I will go a little bit now to the other side, just to go a little bit to the RAO direction, just to confirm in two different projections that the wire is not completely offline. Just if this confirms that this wire is in either direction of the LAD, we will see how we will handle the situation. Phil?
Almost
Okay.
there.
Almost there.
In the true lumen almost.
Now the
almost.
question of the last millimeter.
That's the.
Almost. But as we said, the devil is in the details.
But it
But-
is dancing with that.
Yeah, no, absolutely. I'm feeling very confident. I don't know what is your. We're digesting the easiness of the wiring.
Yes,
So-
this is good. You are the good.
Yeah, no, for sure it's good. Simply, I'm just looking the proximal cap. It looks okay. It looks at the point that we wanted to puncture.
It's a very.
Yeah.
At the moment, it stopped very.
Yeah, so this is exactly what I told you also, Dr. Dobrin. Have a look at the course of this wire. You see that it takes a bending. This is deflecting within the occlusion. You see that the distal part is deflecting. If you take a Gaia next, the Gaia next will tend to
This is
go
next.
more straight. This is next.
You are with the Gaia Next 3, by the way.
Okay. What
Just
Dr.
if
Gelef told me
you
that-
don't notice, but and that was my initial suggestion, but anyway.
Dr. Gelef said that this is definitely in the diagonal.
It's the branch.
Okay. Yes.
Bravo.
Okay. Yeah, well, but this is a little bit premature. What I'm trying to say.
Maybe double lumen catheter there?
Yeah, we have the dual lumen. The main issue now is what I was telling you. We were able easily to wire the diagonal branch. Let's see a little bit the anatomy. One of the things that,
I think we have enough space to make a small dilation.
yeah, the reason that I wanted to discuss, because for instance this is not
The
only for the
small
patient,
bone.
for us we will do that, Valery. But what I was thinking, because the sequence is to dilate with 1.5, reinsert the dual lumen, and wire the LAD. But what I want to say is that I believe that we respected truly the bifurcation here, and that we will have access to the LAD. And the reason that I am saying that is that there was a small notch.
We went into the peak of.
We went to the tip of this stump, and then if we see the anatomy before that,
It was very thin.
yeah,
very
if we
thin
see
in
the anatomy before that in the initial. So you see the wire puncturing through it, it's just a matter of how you handle the wire. Here we saw the stump, and I wanted just to show here in this cranial projection if you look at this diagram, you will see that I was thinking I might take the same wire and try to wire the LED. It doesn't make any sense because we will need two wires anyhow. So, Dr. Gelef, I would suggest that we take a trapping balloon.
2.5 2 PET balon
We'll
обикновен.
take a
дайте.
2.5 to dilate this, to remove the dual lumen.
George, sorry, because there was a problem with your microphone and we couldn't hear you well. What you intend to do now?
So, you hear me well now?
Now, yes. Yes.
Okay, great. So what we suggest, and Dr. Gelef also suggested, we feel confident that we crossed the distal cap in a nice way. This 2.5, Valerian.
Yes.
So we're going to remove the dual lumen now. We're going to dilate the CTO. Let's put it in the other wire also. It's better. And we will reinsert the dual lumen in order to get access to the LED. That's going to be our strategy. Although I was tempted to go into the LED by the same wire, but it's not a good strategy because if you start scratching these vessels, you can easily dissect, and if you dissect the bifurcation, you deeply regret it. So we have to be careful when we do these things.
This is diode 3.
Yeah. So I'll remove a little bit this wire. We have length enough, Valerie, because the wire perforation with these wires is very easy. So we have a 2.5. I don't know why I have resistance. Let me shush. No, we cannot do that. It's a dual lumen. Okay, I'm getting older. We have to insert the wire. It's not a free wire. It's the microcatheter is on top of this.
Time is inescapable. Okay, so now what size of balloon you will use as a
This
diameter?
is 2.5 for 7 French, although in my experience 2.0 is also working well in 7 French. We have some friction to insert the trapping balloon.
No, I mean for the dilation of the CTO.
Excuse me? 1.5.
Okay.
We're going to take a 1.5 millimeter balloon
Yes, that
to
would-
dilate the lesion. Okay. I managed, Dr. Gelef. So we will do it with 1.5. And then I think this will give us enough space to, 6, 8, 10. Will give us enough space to reinsert the dual lumen.
By the way, now
I have to be
crossing
honest, I had
wires-
little faith in the antegrade approach here. Dr. Gelef, why don't we remove that? I was more mentally prepared that this is going to
Едно и
be
5 балон дайте.
a retrograde case.
I think that this is the
nice.
first antegrade case I see
Yeah,
in the last
absolutely,
10 years,
absolutely.
maybe even more.
No, what I'm trying to say, Valerie, the shorter wire is the wire that we want.
No,
This
they
is,
are different.
I know, but the shorter is the one that it is more distal, so this is shorter.
No, this is the one. This is
You think so? Let's
yes.
see.
This is the guy is the
Yes,
the
okay.
white group.
Okay, let's remove that. All right, we're going to do the 1.5 dilatation. And then we're going to reinsert the dual lumen.
You
It
don't,
becomes a nice case.
you decided to leave Gaia to make a balloon crossing over Gaia and then to use it as a rail for double lumen catheter and with another wire to go back into the LED. Yes? This is your strategy at the moment?
Yeah.
Because I always feel a little bit uncomfortable leaving Gaia.
Okay, let's start dilating there. We have resistance. When we have resistance, I start dilating. Just a second, Valerie. I will push gently a little bit more. Yeah, we entered this. Okay,
I think
6,
we
8.
are in
Yeah,
the
yeah.
middle of
One thing that always
6, 8.
down. One thing that always is happening, we had the wrong perception in the past that if you don't cross, you don't dilate. That's a wrong message. As you can appreciate here, 6, 8, 10, the main
10.
thing in the CTOs down is that you have a shaft. It's not, the resistance is not in the tip, but it's in the shaft of the CTO balloon. We crossed, as you see, 6, 8, Valerie. Yes.
It's very distant.
Eh?
Isn't it very distant?
Ah, you think so? But it's okay. We will dilate anyway more proximal. One thing that you don't want to do with these wires down is to push too much and push and pull because the tip is moving too much and you can easily perforate by that maneuver only. 6, 8, 10, I think it's over there, Valerie.
10.
Down. 6, 8, 10.
This is what I mean, because to leave Gaia,
Ten.
I
Down.
personally always cross with the
10,
microcatheter,
14.
exchange the wire on a regular one and do that.
Down.
14.
Down.
Moreover, the
Okay, we will remove the wire now. And, oops, don't.
Sorry, no, that was my fault.
No, don't worry, it's okay. We have them.
I mean,
No, don't worry, it's okay. We have.
it's just
Let's take the 2.5 balloon. We will do trapping of the wire first before we advance. Or we don't need it. It's okay. Yes. Let's insert. One thing that we can do, Valerie, I would suggest, because we didn't create any dissection, I think in this case it's justified that we make a short film to see whether we can have any LAD flow. Most of the time I don't prefer it, but in this case I feel confident that we did what we said from the beginning, crossing. We're going to make a short film and we will see whether we have any penetration of contrast into the LAD. Yeah, you can appreciate that we have.
the wire is.
Distally, that's okay. Yeah, thank you, Valerie. No. Let's see the previous film. That's clearly an indication, as you can appreciate here, that we cross the bifurcation. Let's insert the dual lumen here, Valerie. That we cross the bifurcation properly
Do a woman with a.
sometimes
because
this
we
step is
already
the
have
most
flow in the
difficult
distal
one
LAD.
to go back.
So we see the flow in all vessels. We see the flow in the first diagonal. We see the flow in the second diagonal. I wanted to ask you about what do you think of the size of the first diagonal branch? Is it a branch that you would consider relevant for bifurcation treatment, or we just go and see what is happening with this vessel?
Keep it open. Keep it open.
Keep it
This
open.
is less than 10%, so
Thank
for
you.
sure.
There are many
I have it,
people
Dr.
that
Gilles.
even would not notice
I
this
think
branch.
we're in a very small branch because
Yes.
side branch.
Okay.
Side branches.
Just
The distal one you mean?
a short note, there is a coffee outside. We are at the
Let's see
time
a little
of
bit.
coffee break, so if somebody wants to take something,
Or
just feel
Maybe
free
not, maybe not.
to
I
serve
think
yourselves.
It's okay. Let's wire it and we will exchange.
if you are
videos.
interested,
Give
you
me
can
the
stay.
run through, please.
run through.
As I see, nobody wants to drink a coffee, everybody are interested in the case. So this again, Sasuke, you take
Sasuke,
a regular wire for wiring LED.
we're going to take our workhorse wire
Okay.
and see whether we can. Let's make a smaller bend, Valerie, if
Yes,
we can.
I'm trying to put it in.
Okay. You know what? I will do the other way around, Valerie. I will do the other way around. Let's. We need a good wire for.
If we need a good wire, we can take a fresh one.
Yeah, because we might.
Дайте един
Although try that one. Try that one.
пригответе run through.
It's okay.
No, it's going to come, but намерете
From the
друга
backside.
игра. Yes.
Хуан?
Друга игла ми.
Може ли един микрофон да...
Служете го това отзад. Дай си пробваме. Пригответе рантрото другото. Чакай.
I would like to ask
Да,
Dr.
просто
Chico,
some of these
той е за
needles
теб.
That's good.
But if you
Let's see.
about
Let's see.
the
If it goes, goes.
remodeling
Stop wire.
after such a case because we see what a huge discrepancy there is between the proximal LAD, which is around 4, maybe 354, and the distal LAD in this situation is, at the moment, it's around 2 millimeters. We will see probably in IVUS.
Just need to
what will
advance
be,
a little
but
bit more.
in
I
any
think,
case.
We presented in your meeting in September some preliminary data of IVUS guided CTOs. So we were choosing the size of the stent according to the IVUS, which is always much bigger than what angiography size.
Just advance a little bit
If you image with OCT that same CTO 2 months later, we measured up to 250% more remodeling. I mean, your stent is sometimes floating in the middle of the LA of the CTO, even though you have sized the stent according to IVUS. So some remodeling would be to expect. And I mean, these vessels, which now in the angiography are smaller than the guiding catheter, so probably 2 millimeters, 2.25 millimeters, probably we image it with IVUS. The IVUS is on the table, so I would definitely go for an IVUS run. And even though we size the vessel with the IVUS, in 2 months it will be much bigger. And we are now trying to run a trial to optimize the CTO according to the OCT measurements 2 months later.
What I've not heard is about nitrates. Do the patient receive nitrates or not? Of course, this is remodeling, which is on long term. But acutely, what we do is nitrate, filling the patient, nitrate and filling the patient with anesthesiologist there. This is what we are doing. So you will increase the diameter. Of course, this is not the correction of remodeling.
Now, let's do again the trapping. And I think this time we can insert over this wire, if possible. So we got access to the distal LAD, as you can appreciate. Our target now would be to wire we will remove the dual lumen, and we will remove also the wire that we have into the to the distal RCA, which is not necessary anymore. And we will insert the microcatheter to the diagonal branch in order to...
I'm going to pour it
together,
guy.
Yeah, please. I removed a little bit, yeah. Okay. Let's... Valerie, come here to hold before we do anything. Hold all of the wires together, everything, all the materials down. So we remove the dual lumen. It's congested, the microcatheter is a little bit congested, the guiding is a little bit congested. Before we do anything, no, this one is okay. I need to advance, let me just have a little bit. I need to advance a little bit this. So hold a little bit everything, Valerie, including this, so we can just remove the...
George, why don't you remove this guy? I think that it would not be a problem. Not this
Just
one.
a second, it's okay, I see.
Inflated?
Yes. No, I wanted to inflate the... It's okay.
We have to remove it and...
Now it's okay, it's back. No, I wanted, in order to inflate...
Yes, you have to put
I
it
needed
back into
to...
the guiding.
Okay. All right, let's go. Everything. Yeah, we have it now. I have it, Valerie. Let me just... Yeah, the balloon is coming. Simply this wire, I killed it. We will see how we will replace. We will fix both wires. We have everything in place. The 7th French is a little bit congested.
You can take a new one, a fresh one.
No, it goes easily because it's over the wire. And we're finishing. When we remove this, when we remove this, okay, inflate 6, 8, 10. I don't know if you can see this our balloon there distally. So let's remove a little bit the dual lumen first now. I will replace that. We will replace that.
Just to cut it, to be sure.
No, there is no problem here. Okay. We have a good, it comes okay.
The pulling?
Yeah, please. Everything is stable because the 2.5 balloon is, everything is stable. So we have a lot of wires, we have trapping with dual lumen, we have 3 wires, it's not the usual situation, but we have everything under control, all of our materials are there. That's a good sign. Okay, we have out the dual lumen. So let's decide, first of all, I would suggest that we insert the fine cross into the to exchange first of all the diagonal, to be sure. Let's flash this microcatheter a little bit. I don't think so that we need the radial, Dr. Galef, anymore. Do you think so?
Just let's.
Yeah, I will just... Let me see where is the contrast from the right side. It's okay now.
Just to make a final shot and we can remove.
Yeah, that's what I mean. Give me a little bit of the right if I can. I'm already out. Let's go to the LAO. You can take a diagnostic now that we are out. Let's see. We're going to check a little bit the right coronary. The guiding was a little bit aggressive in the right.
Ето е даден.
Contrast, Valerie? I
That's
think it's
fine.
okay,
Everything's
correct?
fine. Yeah.
Okay. Let's remove this catheter. It's a little bit aggressive for this right as far as we don't need it. That's good. We have it.
Let me-
We have already the trapping balloon inflated. That's why you
Yes.
don't see any pressure. Let's clean the materials a little bit. And then give me
fine
the fine cross. We will insert it into
In the Gaia.
in the Gaia. We will replace the Gaia with another wire.
What is the pressure? What is the pressure? The pressure of the patient?
We are at the moment fully obstructing the guiding because it's inflated. You will give. You will give.
I want to know what is the pressure, arterial
It's
pressure.
around 120, 130. I will
So-
give you the pressure in a moment. I
Because
will give you
I
the
think
pressure.
it's important now to inject nitrates and to renew, to put some volume, renew, to try to approach the ideal
This is
diameter for your
150,
stent.
Valerie. We
Yes,
don't have
I know.
enough length.
Дайте fine cross 130.
Okay, deflate just to see the pressure a little bit, Valerie, and we will inflate again. So the pressure of the patient is 120, as I told you. Yeah, it's around. You see the do you see the hemodynamics?
No, we don't.
Okay,
We don't
yeah,
see.
the pressure is 120, simply because let's inflate again, and we will.
We don't.
yeah.
We don't see. But 120, you can inject nitrates and then fill and.
I will
in few
exchange the
minutes.
wires first. I will exchange the wires first,
Виж сега.
and after exchanging the wires, we will do any kind of manipulation
Отвътре
necessary
никъде, той не
in this
Тук, за
direction.
да не се виж го как се... Не е добре. Това е промивката първо, как трябва да
This
се-
short one?
Yes.
So another question: what will be your choice of stent? One stent for each bifurcation in the main vessel, or a single stent?
Okay, Valerie, we have it. That's difficult.
So if you use a single stent, you will have to do 2 pots.
But if we have a very nice stents nowadays, for example, on a platform from, let's say, 3.0, we can
Save
go
that.
up to 4.5. So we can adapt it very easily for both bifurcations, I think.
I think that the best strategy crossover in.
Run through.
So a double crossover
Yeah,
across the 2
We'll
diagonals.
put
yeah?
the Sion black in the LED. I will change this wire also. Okay, give me the run through. Thank you.
Which way?
The distal LED is a little bit destroyed. Let's put that in the diagonal first. My strategy in this case, because what I see here, if we play this projection, before we do all of that, the next one, the previous one, I believe, this one here, is that the ostium of the diagonals, maybe the first not, but the second one is quite free. So I believe that the best strategy, especially for the distal diagonal, is to cross over it. I would be delighted to see a final outcome with one stent crossovering the 2 diagonal branches. I don't know what is, this is better, Dr. Galef, no? Okay, I will just remove the... What is your opinion?
For me, a crossover, a long crossover,
Yeah.
And you have to adapt the diameters. You will have 3 diameters, so you will have to do 2 pots.
I will take out. Yeah.
For
Okay.
me, certainly more than trio in proximal segment.
Done.
Between the 2 diagonal, something like 3, and distally.
Okay.
You can
The
inflate.
very first thing that
You can inflate the distal 3 millimeter at only 8 atmosphere or even 6 atmosphere. It's enough to open a stent, just to have
Okay.
the 3 diameters.
Let's take it to
A question.
0.5 balloon.
Since you have a
Let's take
60
it to 0.5
megahertz
balloon to
IVUS on the
dilate
table,
the lady first.
would it be worth to have a look with the
No,
IVUS
vice
at
effect.
both
Valerie,
bifurcations and just to
Yeah,
know
from,
for sure?
from one with,
Do we have a long one?
I think a good option, because you have IVUS, a good option will be to use IVUS.
Just to see what
You
scenario
have to see you
at
have
the-
3 segments and 3 diameters, so you will plan your stent deployment. And to get the stent deployment at the diameter you have found, you have to give a pressure for the balloon for post-dilation, a pressure and at least 2 inflation, because a balloon is not open at the first deployment. You have to know that.
But what if we think in a little bit different way now? It's 2026. I would do a very nice lesion preparation. I was guided for sure from the, let's say, distal to the second bifurcation, and then evaluate once again. And I completely agree with what you said, and we have very similar results. We don't stand CTOs nowadays. We put it on the table 1 or 2 weeks after, and we see that the vessel physiology is completely different after the procedure. And the measurements that you told, yeah, we also observed that the 2.5 vessel becomes like 3.5 or 4. Yeah, I'm a very big fan of not doing anything in the procedure itself, rather controlling, checking, and then stent it if when needed, or like leave it just with DCB. I mean, not DCB up front right now, but if you check it like in 2 weeks, I think it's, I don't know what you mean about, what to think about the time frame, which you said 2 months. But I think the physiology, if you read it, let's say in some articles, the physiology after the CTO opening, it takes 2 hours at least. So what we are doing at the end of the procedure, it's not the same as 2 hours later.
Actually, all the people which are getting involved in this project, in this trial, the timing was one of the most fascinating topics of discussion. I think we need some, it's not the physiology that you can see 2 hours later, but it's also the remodeling, which takes a longer time. So I arbitrarily propose 2 months for some reasons. I mean, I gather all the evidence stemming from IVUS studies. Gary Means was on board, and he also recommends these 2 months. He agrees with that, because the evidence seems that after 2 months, most of the remodeling of the artery is completed, according to old IVUS studies. Maybe they would have to be updated for the specific scenario of the CTO, which is not so clear. But at 2 months, it seems that could be completed, and the drug elution lasts 180 days. So after 2 months, we still have drug on the stent. Yeah. Otherwise, we have to probably to complete the second step with a drug-coated balloon. And then our financial manager of the hospital or the insurance companies will say, man, this CTO is becoming unaffordable from a financial point of view, because we are adding a second procedure with OCT, still with a drug-coated balloon. On top of that, then the costs of the revascularization increases. So we thought that 2 months could be a reasonable balance, because we still have drug. We can stent it. I mean, if we can afford just ballooning and then checking without stent, it's okay. But it's not always possible. Sometimes you need the stent to keep a good timid flow, which is the main factor for the remodeling.
Yeah.
We were doing that coronary angiography after 2 months. And so we know that this remodeling is occurring, especially if it's an old lesion. An old lesion, remodeling is coming. But if we know that remodeling is coming, you can anticipate to put a bigger stent.
Yeah, I mean, that's why we propose to use some stents which have more capability to expand, to overexpand later on. That's our initial proposal.
Yeah,
But
I agree with you.
it's
I agree.
still in discussion. You are welcome to join.
Guys, just I suggest to
You
make
see, sorry to interrupt your discussion. That's our angio after nitro. We were just discussing with Dr. Gelev here for two issues. The first issue is that I don't know what is your opinion about the second diagonal. In our view, this is probably accordion effect, and we are prepared to not to touch this diagonal. We want to cross over by having the wire in there, point one. The second thing is that the proximal vessel is around 3.5 to 4. But I was just discussing with Dr. Gelev, we're going to do an IVUS for you. I was just discussing with Dr. Gelev that we might use two stents, one 275 distally and one 3035 proximally, but he feels very confident with one stent. What is the size of the stent that you would have liked to have, Valerie? 3.0?
We can put a 3.0.
3.0.
And this 3.0, if you inflate it on 7 atmospheres, it will
Okay.
go to 78.
Okay.
But it can be overextended up to 4.5.
Excellent. So I don't know your thoughts on that direction. This is post-nitro. We're going to do an IVUS first of all, just to show you a little bit the...
I agree with the measurement you propose, but you have to see that what is making decreasing of the proximal LED is first the very big diagonal which is here. So before and distal to the diagonal is not the same diameter. So you have to do a pot there, and after that a pot in the middle part between the septal and the second diagonal, and after that we'll have a good result.
Okay.
just George, sorry, but we will leave you for a while.
Yeah,
just
okay.
To make a 5-minute break, just if somebody wants to take a coffee or some
Let's go, Valerie.
beverages, they are outside, and then
Why don't you just see the IVUS and then you go?
we are looking at you all the time. By the way,
Okay,
you are
that's
on
good.
the screen, and if somebody wants to continue, I will be on the
Excellent,
podium. So I'm here for sure.
Excellent, excellent.
I
Okay,
will have a look too.
I see that Vlado, Mitov, and Yuri are here.
Let's start the
also,
pullback. Yeah.
So in general, the panel is here.
so the distal LED is a quite collapsed vessel. I will keep on commenting, you do what you have to do there.
Okay.
So we just, the distal LED I think is still underperfused, Dr. Gelev. And we see here we're coming into the CTO part now, and the vessel is growing. You see the diagonal there at 2 o'clock. Yeah, the vessel is for sure 3.0 there, so it's a good choice, I believe. We see the bifurcation. Still, we're in the CTO part.
But you see, we are true to true.
We're
Definitely.
completely true to true. There is no subintimal course at any point of the crossing. All the way, another small branch there. I didn't see the septal as yet.
It's coming.
Yeah.
We have to see the diagonal and
Yeah, you see a little bit of hematoma around here at 1 o'clock based on the first wiring, initial wiring. But we are very well there. There is no subintimal course, but you see a little bit around 12 to 2,
This is the
where the
diagonal.
first, and this is the first diagonal now, and this is the septal. So we're true to true all the way. And as we see here, the proximal vessel is around 4.0, and we'll go a little bit more because there was a stenosis after that. Yeah, this is 4.0 at least. So a 3.0, as you said, and then we have to pot both vessels based on the diameter, and then we see what we will get. It's 4.45, something like that.
But George, based on the proximal lumen, I mean, this vessel also distally it should become very big. I'm really a fan of cutting and scoring and stuff, and you see a lot of fibrotic tissue inside. So maybe I know some cutting and to make additional lumen gain also will improve the stenting what we put inside. What's your
You suggest that we do a little bit more
plug modification? Yeah.
plug modification proximal to the second diagonal.
Yeah, yeah.
Okay.
Because there's a lot of
What do you
fibrotic
think?
tissue.
In my opinion, we should always keep in mind that we can
Post-dilate at any
we
point.
can evolve the dissection which can go into the diagonal. Right?
Yes.
So
Too
in
much
this,
of pre-dilatation might cause this additional. What Dr. Gelev says, and I tend to agree on that,
we
is
don't
that
have calcium on the.
we didn't see a lot of
eyeballs,
calcification, and we feel very confident about
Extend
the expansion of the stent. So let's follow the policy of 30 by 38, 3038 to cover, and we'll go to 7 atmospheres. We're going to take Nagomi that has a very good capacity of expansion.
We
The 30
discussed
can go easily up to 4.5 proximally.
regarding
Here, what it would be very interesting is to discuss with you the pod, because we have 2 diagonals. Assuming that I have a little bit of, for the second diagonal, I'm not afraid so much, but for the first diagonal, I have the feeling that it might be lost. We're going to see. So we want an
George,
agometry.
if I may,
Yes, please.
just to be from the angulation perspective, the risk for the first diagonal is very low, but for the second one is high. So
I have the feeling that the
Just-
ostium of the second is, this is,
No,
how do you call it?
I'm not talking about there is a pinching, but this is accordion effect.
Okay.
I'm not speaking about that. I'm speaking because when you stent it, the carina will be pushed because the angulation is very steep, and
Okay.
it could be problem with the second diagonal. For the first
Okay.
one, from the angulation again perspective, I don't think that something significant will happen with the first diagonal. So.
Okay.
Maybe keeping quiet and doing pot, good proper pot with the second diagonal, and not to rush too much with the first diagonal, because
Do you propose a different strategy from the crossover to both diagonals?
No.
Or additional preparation of the
no,
diagonals?
no, just
okay.
just keep it open
Okay.
as
okay.
much as possible with 2 pots, but with
Yes,
different
yes.
size.
That's what we're going to do. We're going to implant this stent. Let's make a film. Based on the previous projection, I went, just to give you an idea, maybe I need to go a little bit more distally.
To be honest, personally, we
I think it's
discussed
okay, maybe 1 millimeter
with
more
Ravi,
distal.
we
But
discussed
we're
with
going to make a film.
this
Let's make a film
strategy
together.
with the scoring balloon and DCB,
I think it's good, huh?
but
Okay, let's implant there.
we'll see.
Yeah, it's good, it's good, it's good. Maybe 1 millimeter back. 1 millimeter
7.
back. Okay, go ahead. Go ahead, Dr. Gelev.
7.
Yeah, please.
But definitely you will need
the
another
patient
stand
wants to pee.
proximally.
Yeah, we will take a break. This is 7 atmospheres. As you see, even in low pressures, even less than that, yeah, 7, the balloon is reasonably expanded.
Maybe 30 seconds will be good time for inflation, just to
Absolutely,
wait.
yeah, we keep it there.
Yeah.
I'm not very patient myself in these kind of things, but Dr. Gelev is much more disciplined to me.
He will keep a discipline on you.
No.
Okay, no, he says no, so you have 2 undisciplined operators. Let's deflate them. Okay, yes, please go ahead, yes. So we give some time to the patient, a couple of seconds.
Guys, let's see the angio after this one, and
Yeah.
we will continue with the program because we are
Absolutely, yes.
12 even more minutes late.
Yeah, okay.
Out of the
let's,
schedule.
Let's remove the balloon, and then we will just give you an angio, and then we will see what we're going to do. I lost the wire. Ah, not. Okay. All right, Dr. Gelev.
Yes.
Flow everywhere. What I clearly see is that I don't know what is your definitely for the proximal one we have to do work because the stent is not fully expanded. The distal stent looks quite well, and for the first time also we see the distal LAD fill tab. We have flow everywhere. would you do anything there, or just remove the second diagonal wire, do pot, and then we have to do a kind of a 3-5 pot before the second diagonal and 4-0 before the first. What is your opinion to that? And then you can go.
But we have
You
the
do
measures,
pot
so
before
we-
removing the wires. So
Pot before removing the wires.
yeah.
So what balloon are you going to do for the second diagonal, and what balloon for the first? Because I think we need two different balloons.
Yeah, absolutely. The two different diameters, and the proximal part is not
3-5
not fully
for the
open.
second, and 4-0 for the
3-5
first.
for the distal, maybe
4-0 or 4-5 for the
3-5 for the distal, but not very high pressure. As you can see, this is very well
3-0,
open.
3-0.
325.
325. Yeah. We measure the
325.
IVUS here, so we will do 325 for the distal and 4-0 for the proximal.
Absolutely.
Dr.
Yeah,
Shaw,
I don't see any dissection at the distal edge of the stent.
No.
So the choice of Dr. Gelev was excellent one.
So after that, can you do at the end? Can you do an IVUS
Yeah, absolutely.
to see if you were successful without using IVUS to guide your stent deployment?
Yeah. Okay. We will
Professor
optimize
Tsianos,
the
is
standing.
it
and
possible
then,
to have
yes?
one angio but with the pullback of the wire in the LAD?
Yeah. We will do all of these things. So let us work. Take your break. For those that they want to follow, we will keep on optimizing the stand expansion and the potting. And one question that I have, and I will ask it again. Do you think that if we have T3 flow in these diagonals that we need to do kissing or not? What do you think?
For the side branches, yes, they are open. Maybe you have to reuse nitrates, and you will see if you have.
Okay.
You don't
If we
exchange
have
the wires. If the vessel has good flow, is okay.
That's it.
The flow can be not so good because it was collateralized.
Yeah.
So
yeah.
if you come back in 2 months, you will see something different. So,
Okay.
But you won't come back.
Okay, one last question. What is the rationale of potting before the removing the wire? It has to do with just as a marker, or there is another significance of pot before a wire removal?
Yeah. Yeah, no, the diagonal are patent and the flow is normal, so don't worry with this.
Okay.
So do the pot, remove the wire, and the program is finished.
Okay, so we'll do 325 distally pot, and then we will remove the
And
wire.
then IVUS to show if everything is on the wall and well deployed. So it will be
Okay.
interesting. So we
All
move
right.
to the next session here. So
Excellent. Thank
see
you
you
so
later.
much. Thank you.